So good afternoon, everyone, and welcome to today's PHO Public Health Ontario Rounds presentation on the geography of sex, men who have sex with men in the suburbs. My name is Dr. Leanne McDonald. I'm a public health physician here at Public Health Ontario, and I will be moderating today's session. Before we begin, I want to recognize that June is Pride Month, a global movement and celebration that recognizes the history, resiliency, strength, and achievements of the 2S LGBTQ+ community. As an ally, I am privileged to moderate today's session during Pride Month. Recognizing that it is also National Indigenous History Month, before we start today's session, I'd like to start with a land acknowledgement as an opportunity to reflect on our accountability to continue building relationships with Indigenous people grounded in understanding and respect, and to foster reconciliation. We acknowledge that the land we are hosting this virtual education session on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. I'll now mention a few housekeeping items before we get going. Today's event will have an extended Q&A segment, so we have up until 1:30 p.m. EST for some discussion. We welcome you to join us. We really hope that there'll be good engagement during the interactive panel discussion today. We've disabled the chat pod to limit any distractions during the presentation, but at any time you can enter your questions in the Q&A pod as well as during the discussion, and we'll look forward to them. The discussion and question period will be following the presentation. So if at any point you need help with any technical issues, please email capacitybuilding@oahpp.ca. And finally, I'd like to state that as the moderator of this session, I don't have any conflicts to disclose. I am employed by Public Health Ontario and a co-applicant on some CIHR funded research. So now it's my pleasure to introduce our main speaker for today, Dr. Dion Gesink and her colleagues. Dr. Dion Gesink is a professor at the Dalla Lana School of Public Health at the University of Toronto. Dr. Gesink has built a research program investigating the social epidemiology of sexual health. She seeks to better understand the ways culture and environment shape the patterns of our sexual behaviors and relationships. Dr. Gesink uses novel approaches to navigate the complex connections between physical spaces and the people and communities who inhabit or pass through them, which provides insight into how to improve sexual health outcomes for vulnerable, marginalized minority groups and the general population. Currently, Dr. Gesink is studying the geography of sex to reduce STI transmission among men who have sex with men. I'll very briefly welcome as well our community organization partners for today from Moyo Health and Community Services, Executive Director Jillian Watkins. Welcome, Ms. Watkins, and 2S LGBTQ+ Training and Capacity Coordinator, Winston Wong. Welcome, Mr. Wong. Thank you both for being here today. And with that, over to Dr. Gesink, to Dion.
Hey, thanks so much, everyone, for having me. And it's really an honor to be able to kick off Pride Month by sharing our study with you. And I'm very interested in hearing what you all think and whether or not this resonates with what you see in your own communities. So today I'm going to talk about our study of the geography of sex. This is work that we've been doing for a few years now. And with me, as Leanne mentioned, are Jillian Watkins and Winston Wong. None of us have any conflicts of interest, and this research has been funded by the Canadian Institutes for Health Research. So the objectives today are to explain how suburban MSM, or men who have sex with men, are connecting with urban, suburban, rural, and sexual health settings in the Greater Toronto Area. We want to discuss concepts such as convection mixing and activity space and describe how these concepts might inform interventions going forward. Also identify factors that affect positive and negative sexual health care experiences, and discuss outness and how it might influence sexual health care seeking decisions for men who have sex with men. So the way I've got today's talk structured, I'll give you a bit of background on the social geography of sexually transmitted infections, and then I'll give you a brief summary of our study the first phase of this research, which was the Geography of Sex Urban Edition and focused in Toronto, and then move into our current research, which is the Geography of Sex Suburban Edition, which is happening in Peel Region, and provide some preliminary recommendations based on what we've been finding, and then open it up to discussion and any questions that you might have. So for a little bit of background, so I'm a sexual health researcher. I'm very interested in relationships. My motivation or my vision is people to have happy sex and healthy babies. And sexually transmitted infections is the one thing that sort of threatens both those things. So I've been working in sexual health for quite a while now. And I want to start off by talking about core theory, just briefly, and because this has driven a lot of our thinking around how we intervene on the spread of sexually transmitted infections. This is a theory that there's a core group of people who are either infected 20% of the time or more, or who happen to share a set of characteristics, for instance, commercial sex workers, or gay and bisexual men who have sex with men. There's a lot of different ways we've defined the core group in the past. One thing that we've also seen is that partner selection historically has been a local phenomenon. People who are part of a core group tend to find their sexual partners more locally than further away. However, we don't really know how apps has changed that. But what we have been able to see is because of this local partner selection, we can see that we get these core areas that can be also defined geographically, where we have higher levels of sexually transmitted infection rates in geographically definable core areas, at least in urban environments. And we can even see that those core areas can overlap for different STIs, even though the group that's affected might be different. So for instance, chlamydia affects young women, HIV tends to be more older gay men. So regardless of the two different populations, the geographic areas that have the highest rates tend to be the same and overlapping. The other thing we know is that people move around for sex. They move to reach their partner. And when we looked in Baltimore, Maryland, at a syphilis outbreak before, during, and after the outbreak in the 1990s to early 2000s, we saw that there were these sort of two initial core areas in the east and west here of the area. And you can see we've tied the next few slides I'll show the movement and spread of the rates of infection over the course of the epidemic. So the scale here will stay the same. So what we can see is that we have sort of intensification and expansion of STIs in the core areas, and then they leap out. I'm going to backtrack for 1 second to this third area out here to the northwest. And then everything recedes back into the core areas after the epidemic. If we untie the map to the just to what the rates were at the end of the epidemic, you can see that there are still these two core areas and then this new third core area of infection that persisted after the epidemic. So with the geography of sex then, a sort of conceptual definition that I use to describe it is, it's the social process of partner selection in the context of the spatial relationships between individuals and their natural and built environment. So another way to think about this, which might come naturally to many of you, is the idea that we all live in a local environment. If I'm a gay man and I live in the Village in downtown Toronto, in the summer during Pride, this might be my environment, both socially and physically. If I live out in the suburbs up in North York and it's the middle of winter, I have a very different context that I'm living in. And then myself and my partner are going to have some kind of combined environment. So if we both live in the Village down at, say, I live at Church and Wellesley and my partner lives at Carleton and Jarvis, we might go to the coffee shop that happens to be just below the Hassle-Free Clinic that's right there, just a couple blocks away for our first date. And we can always get a test if we feel like it. If, however, I live in the Village and my partner lives in City Space or City Place that's down towards the Sky Dome, In the summer, this can be a very easy to traverse distance. I could bike there, I could walk there, depending on how ambitious I am. In the winter, though, this can feel like an insurmountable distance. So thinking about sort of this concept of cores and core people and where people are, and looking at the rates of STIs for Ontario, we know that there's a mature syphilis epidemic and that gonorrhea rates are rising. So this is you can see here, at least pre-pandemic, the rates were rising, especially for men. And the syphilis rates, despite being high for a long time, have been continuing to increase. Again, also much higher rates for men, and that the majority of people affected were gay and bisexual men who have sex with men. We had done a mapping exercise previously to look at where were the core areas. Was there a core area? What we did see was that there's a core area in the downtown area of Toronto with these outbreaks to the east, west, and north. So if you live in sort of the downtown core area, the relative risk of being a syphilis case is 12 times higher than if you live outside of that area. If you live in any of these 3 outbreak areas, the relative risk of becoming having syphilis is almost 3 times higher than if you live outside of these areas. One thing that's sort of a bit of a question mark is whether or not this core area, which has persisted over time, whether that core area has expanded and that these outbreaks are actually sort of expansion of that core area, so that it's really just covering all of downtown Toronto. And partly that has to do with mainstreaming. So we've got the village that happens to land within the core, although it does expand beyond the village. But we have Queen West, or also known as Queer West, where we've got more mainstreaming into the what would historically have been sort of not the village. We've also got City Place. And if we look at the availability of sexual health services, we can see that actually in those areas, we've got pretty good coverage. This is work that was done recently to look at access to healthcare, sexual health services in Toronto. So part of what we're seeing might be because there's easier access to sexual health care. But it also means that there's a lot more resources to address STIs. So there's a bit of a question of why are the rates of STIs still high, even though we're allocating resources to the core and to those outbreak areas. So the first thing the next thing we thought was we need to talk to guys to find out what is going on. So the purpose of the Geography of Sex Toronto edition was to study the spatial relationships between sexual partners and their environments for gay, bisexual, and other men who have sex with men in Toronto. And the results were intended to inform the response to the ongoing syphilis epidemic. So we interviewed 31 guys in between June and July 2016. And what we learned a bit about how guys find partners. So we learned that it has to do with the intention. Are they looking for sex? Are they looking for dating? Are they looking for a relationship? Once they decide their intention, they move on to the community that will best fulfill that intention, whether that be an online community or an offline community. And they talked about different apps even having different vibes about them. And then let's say they were online, they would look at the potential partner characteristics. They'd look at their external preferences first, and then they would move to the sort of some tells about the internal personality of the person and what their preferences were around that. And then they'd look at the interaction experience. So the top 3 external partner characteristics included attractiveness, geographic proximity, and availability. So guys pretty much said, if he's good looking and he's nearby and he's available, that's the guy I'm going to go for. Which also leads then back to this idea of how are guys moving to each other? How far are they willing to travel for sex? Because this can lend insight into how far they're willing to travel for sexual health services, right? Sex is a pretty powerful thing. So you can imagine that guys will likely travel further for sex than they would for sexual health services, all things depending. So we asked guys about where they lived, where their partner lived, and where they met to have sex. And what we found was that based on the responses, we could identify 6 geosexual archetypes. One was hosters, which was the term that we borrowed straight from guys themselves. So these were guys that called their partners to them and sort of hosted at home, had sex at home. Then there were guys we called house callers who had sex at their partners' houses. Guys that we called rovers who had sex in more public places or spaces, not their house and not their partner's place. There were guys who did a combination of these 3 base identities, which was some guys we called privates. They'd either host or have sex at their partner's place, but not in public. There were other guys that would have sex at their partner's place or out in public, but would never host. And then there were what we called geoflexibles, who were comfortable either hosting or going to the partner's place or going to a public place. What we also started to notice was that there were some, you could actually start to see differences amongst these archetypes. So for instance, hosters had a lot of partners, and most of their partners were found online compared to rovers who had very few partners, and none of their partners were found online. The average distance that they were willing to travel, hosters traveled nowhere, and rovers tended to travel still fairly locally, but about up to 4 kilometers, a little over 4 kilometers away. And when we looked at rates of, looking at race, we found 100% of hosters were white, 33% of rovers were white. And when it came to ever having had syphilis, both these groups, all of the guys we interviewed had syphilis in the past. The only other group that had syphilis was geoflexibles. So this kind of led insight into the idea that if hosters are only having sex at home and rovers are only having sex out in public spaces, these 2 groups are not actually meeting each other and having sex with each other, which suggests that the geoflexibles might be bridging. We've either got 2 different epidemics, one amongst hosters, one amongst rovers, or the geoflexibles are bridging these 2 groups and spreading infection. We also, when we sort of mapped out the distribution of our participants and their archetype, we hypothesized that there was maybe a 7th archetype, which would be guys that had sex at their partner's place or out in a public place. We called them sirens, with the idea that maybe these are guys who call partners to them, wherever they are is where they're going to have sex. And so this might be what the movement pattern could look like. We then confirmed that this group does definitely exist using SexNow data, which is the large biannual survey that goes out across Canada through the CBRC and manages to recruit anywhere from 9,000 to 14,000 guys across the country. So we found that not only do the sirens exist, but that you can see differences in bacterial STI prevalence amongst the different archetypes. We also found that the prevention strategies were not so different among the archetypes. Most guys were not using PrEP or condoms, and very few were using PrEP and condoms. Most guys were in the SexNow study were using PrEP, and then some were using condoms, but the use of both was limited. And you can see also that by archetype and prevention strategy, the rate of STIs is a little different also. So the proportion of bacterial infection. So we also asked guys in Toronto what they knew about STIs and syphilis. And what we learned was that they did not know that there was a syphilis epidemic happening in Toronto. They had no knowledge of syphilis symptoms. They often would say, hey, syphilis, that's still around? Wait a minute, isn't that something Al Capone died of? Wait, isn't that treatable? And as soon as they got to treatable, they were like, yeah, I'm not worried about syphilis. And this was true even if they'd had a previous infection. So guys that were had their infection caught through screening did not know the symptoms of syphilis. Only the guys who'd had syphilis and it got identified because they had symptoms knew what the syphilis symptoms were. There was little concern for syphilis, but still a lot of concern for HIV. And most of the STI prevention that guys described centered around methods to prevent HIV transmission. We asked about, they also said that asking a partner about their STI testing practices was much better than asking about STI status. It was less stigmatizing, and it gave more information about somebody's sexual health practices than asking them if they had had an STI in the past, which I think is a valuable thing to think about when messaging. They had mixed attitudes towards condoms. Some of the older participants talked about the condom code that still was very strongly emblazoned in their minds and practices from the AIDS epidemic in the 80s and 90s. And there was some expression of concern about how condom use might change now with PrEP. And nobody was using condoms for oral sex. So based on the interviews that we did, I then sort of did a pass to look specifically at geography and how it connects to sex. And this was sort of a pervasive theme, is that geography is actually quite important in terms of sex and partnering. And as one participant described, I work near a major intersection downtown. I'm mobile on bike only. I don't drive. So basically, if you are within 2 or 3 subway stops, or where I am at work, or 5 to 10 minute bike ride, I could engage with you. If you were 7 or 10 subway stops away, or in the suburbs, or somewhere that I couldn't bike too easily, I would not engage with you. And this was sort of a common repeating sentiment across the interviews. Even with guys living in condos, they would talk about, like, the guy that's on the floor closer to them is the preferred candidate for partnering. On the other hand, we did have a few guys that lived a bit further away, that more on the margins of Toronto, like North York. And there they talked about feeling more isolated. So as one participant described, I would say about 90% of the time I'm traveling, I would say I'm traveling downtown, because there's not really anyone in North York that I've come to know that way. I think there's been like 1 or 2 guys, and it was great, but one of them moved to Oshawa, so that was out of the question. And then most of the other people that I do, if I see regularly, they're downtown. So I come downtown and then I go with them. And so there was this sort of consistent sentiment that guys were going to be moving to the downtown core to find partners where there was a chance that they'd have more options. And then again, the idea that there was both social and sexual isolation happening with the suburbs. So as one guy described, when I was living downtown, I was very sexually active. And now that I'm in North York again, it's kind of slowed down. So we looked at how far and where our participants were having sex with like where their partners lived. And what we found looking at this matrix, where the partner's residence could be living in the core area of the outbreak area, or a suburb, more suburban area, and where their partners were, whether they were located in a core area, an outbreak area, a suburb, a small city, or out of province. What we found was that guys in the core area tended to have sex with guys in the core area. Guys in the outbreak areas tended to have sex with guys in the outbreak areas, and guys in the suburbs tended to have sex with guys in the core or outbreak areas. So we started to hypothesize that there's this movement. Sometimes you'll hear in STI network modeling the terms assortative mixing and disassortative mixing. And so what we were finding is that there's this assortative mixing. So this like with like, so guys in the core area having sex with guys in the core, guys in the suburbs, or guys in the outbreak areas having sex with guys in the outbreak areas. And then there's this more disassortative mixing of guys out in the more suburban areas or more distant areas with smaller populations coming into the downtown core to find partners and meet up with partners. And so we call this convection mixing. So what does the geography of sex tell us based on what we've seen in the urban area of Toronto? That guys are traveling from peripheral suburban areas into the downtown core area looking for sex, not realizing or necessarily caring that there's an ongoing STI epidemic, or more than one, and they're using HIV safer sex practices that do not necessarily protect them from bacterial STIs. And they're returning home possibly with an infection where they may conceal their identity and their sexual health resources are limited. And then they may return later to the core area. So what does this mean about transmission? Peripheral or suburban areas may be important reservoirs for STIs. They may also re-inoculate the urban core areas as guys move and bring their infection home and sort of stay infected and then move back into the core area. So guys in the core might be getting tested and treated more frequently, and then guys in the suburbs are possibly getting tested and treated less frequently, and then continuing the spread of infection through the convection mixing. It also suggests that core theory of STI transmissions is not going to prevent STI transmission in peripheral areas or reduce the burden of STIs in peripheral areas where there's not really core areas, and that we need to pay more attention to the suburbs. So we did, so what do we do next? Sorry, there's a question in the chat. I was curious if information on age was gathered. Yes, we did. And we had guys ranging in age from 18 to about 65-ish, I think. But I can get exact numbers another time. So we started to look at guys in Peel region. We decided Peel because we had a chance to connect with Moyo Health and Community Services. And Moyo was interested in what was happening in Peel. Peel is a very interesting place because it's got two very large cities, Brampton and Mississauga. It's got a population that's over 1.5 million. It's also got a rural community of Caledon. And a lot of, even though these are sort of populations that are large enough to be cities, it's the geography of it is very suburban. And there is no physical village or even business that supports the LGBTQ community. So that sort of community gathering is virtual, and Moyo is quite involved in sort of providing a community base and presence. Okay. So we have a large research team. There's been a lot of people who have been involved in this project, a lot from Moyo and the University of Toronto, and even Public Health Ontario. And the purpose of the project in Peel region has been to explore how peripheral men who have sex with men navigate their sexual lives and sexual health. And you'll notice that I've sort of switched the language to men who have sex with men more for the suburbs, because there's more of the language is sort of constantly evolving and tends to vary by geography. Gay bisexual men who have sex with men seems to be a little more appropriate for downtown Toronto, but men who have sex with men seems more appropriate for Peel, where there's a lot of guys who don't identify as gay or bisexual and consider themselves heterosexual and happen to have sex with men. So some of our questions are we're wondering how peripheral MSM connect with their sort of social communities, so meaning their cultural, racial, ethnic, and religious communities, sexual and health service communities, and how they navigate sexual stigma. And so many of you will know that Peel region has a very diverse population. So when considering how to deliver sexual health services, one question that comes to mind is, does sort of the gay branded, LGBTQ branded sexual health services, is that the best approach for men and other LGBTQ who come from communities where that might still be highly taboo or stigmatized? We're also interested in the sexual health care practices and preferences of men in these peripheral areas. So we were able to interview 44 sexual minority men in between June and September of 2021. The criteria were that they needed to live, work, or socialize in Peel region. So by gender, we were most of our participants were cisgender males, although we did have some non-binary trans and one participant who identified as a femboy. The age range was 21 to 63 years. The average age was almost 30 years old. By geography, most of our participants lived in Brampton or Mississauga, and some lived in Toronto, predominantly more in the Etobicoke part and the North York part, Milton, Hamilton, Guelph, and Cambridge. And then by race, we had a pretty good mix of racial identities, with a large participation from the South Asian community and the white community, but also Black, East Asian, Latino, Middle Eastern, Southeast Asian, and then mixed participants. So what did we ask them about? We asked them about their connectedness and belonging, their sex life, their sexual health, and their activity space. And this was happening during COVID, so it was a little bit complex. We did these in-depth interviews because we needed to ask about life before COVID and life during COVID. So I'm going to start by sharing, so we're still analyzing these data. I'm going to start by sharing the activity space piece, which Winston was very heavily involved in the analysis of these data. We essentially asked guys, where do you live? Where do you work? Where do you socialize? Please map it for us. And this was to get a sense of how far are guys traveling for these things, so that when we think about sexual health services, we can identify, do guys live their daily lives in a very local way when they're living in the suburbs, or do they traverse large geographies? And what we found was, like, some guys had almost this bullseye effect where they lived and worked in the same spot, and then their social area sort of surrounded where they lived and worked. Other guys lived in one spot, so that's like these green dots or circles, and they worked in another place further away, and then they socialized between those places. And then there were other guys still who lived and worked in different places and then socialized widely and broadly in a lot of different places. What we also saw was that the movement of guys that were living, at least in Peel, was not only to downtown Toronto. There were certainly cases of guys who were moving from Mississauga to downtown Toronto, or from Brampton to downtown Toronto, but there were also guys who were going across from more rural areas to more suburban areas, or from suburb to suburb. So there were a lot of options in terms of connectivity to different places and geographies. So their activity spaces were quite broad. The other piece that we've been analyzing more intensively as a first pass is the sexual health piece. So what were we told? We were told that there is no one size fits all in terms of how guys are accessing sexual health care and how they want to access sexual health care for guys in the suburbs. They also described the suburbs being a bit of a healthcare desert in the context of sexual health. They talked about how they access sexual health care, the impact of, like, their outness, or whether they're out to their provider, and they talked about the impact of COVID. So in terms of no one size fits all approach to meeting sexual health needs, so they talked about the geography of their services. So some seek services nearby in Peel, others would travel to Toronto, and others still would actually even go out of country. Their motivation for selecting services had to do with their own level of outness, their desire for high quality care, and that included well-informed providers. A lot of guys described having a family physician in Brampton that they were very comfortable seeing about sort of their other aspects of their life, but when it came to their sexual health care, they may not feel that their provider was informed on how to provide care for LGBTQ. They also were interested in attending friendly, non-judgmental providers and places, and some preferred a shared cultural or religious background, but others did not. It sort of depended. And so, for example, some of the South Asian men described Devi docs who are born in Canada and trained in Canada, but whose families came from South Asia, and so they were very culturally aware, but they didn't have the same taboos around LGBTQ, and so they felt comfortable with those docs. They also talked about accessing a wide variety of services. So some attended STI clinics, HIV or PrEP clinics, some saw their family doc, some sought LGBTQ specific clinics. Some actually went to the breastfeeding clinic because they could actually access an STI test there, and some went to private labs. In terms of outness as a driver of provider selection, there was a varying rationale when weighing outness and choice of provider. So services that were under the radar, such as the family doctor, were perceived as safer, but there was also a fear of judgment from a family doctor, especially if that doctor was shared with parents or from the same cultural background, if they were not sort of LGBTQ friendly already. And some sought LGBTQ specific clinics and would prefer to travel further away from Peel to downtown Toronto so that they could have discretion and anonymity, and they preferred the geographic buffer. Others would express that they would like LGBTQ friendly clinics close to home. And participants described what made a negative experience for them. Some described having difficulty scheduling an appointment, having long times at the wait clinic. Some perceived that the provider had low knowledge on STI transmission, symptoms, or especially the use of PrEP or the prescription of PrEP. Difficulty finding a family doctor who was affirming, having fears around confidentiality. Sometimes a family doc would admit that they didn't have expertise in the area and would refer a participant to another service provider, but oftentimes those would lead to dead ends, and that could be frustrating. And then they also described the cost of PrEP. Participants also described what makes a positive experience. So information being readily available on a website, symbols that demonstrated LGBTQ friendly space, having friendly and affirming staff, ease of scheduling. If the service was fast, so there were no long wait times to schedule an appointment while in the clinic, having confidentiality, the provider being knowledgeable about LGBTQ sexual health, including STIs and PrEP. And then again, a physician from a shared cultural or religious background could be desirable if they were LGBTQ friendly. Participants did describe the impact of COVID-19 on sexual health access. The pandemic, as you all probably know even better, had mixed impact on access to sexual health care. For some, sexual health care became faster and easier than usual to access, especially with online access. And being able to schedule for a specific appointment window instead of just sort of queuing up for the clinic, and getting in and out of the clinic quickly increased access to remote access to testing and telehealth. For others, COVID resulted in local clinics having reduced capacity or it being almost impossible to schedule an appointment, and sometimes even the clinic being closed for periods of time. And resources redeployed. Participants also described concern around stigma in COVID-19. So there was definitely a fear of judgment for needing an STI test during a time of lockdown or social distancing, and a fear also of exposure to COVID-19 while seeking services. So some preliminary recommendations around what we've found between both studies. There's an urgent need for more permanent LGBTQ-friendly sexual health resources in Peel. Taking a broad approach would be helpful. So improve baseline level of LGBTQ friendliness and sexual health competency across all healthcare providers, and having innovation in STI and PrEP clinics. So exploring innovations in service to improve accessibility, efficiency, and patient experience. We also got told hooking gay people up with gay medical support, and this includes figuring out how to encourage people, especially young gay bisexual men who have sex with men, who have the same physician or healthcare provider that they had with their parents, which can create a bit of a barrier to open communication. So updating that. They also talked about increasing sexual health resources in non-urban areas and ending shame, because there's definitely a lot of shame. So that winds down what we've been learning so far. Again, we're still analyzing our data. So there's still more to be learned about connectedness and belonging and sexual life. But I'm curious to know whether any of this resonates with other parts of Ontario and then what we should do next, because now that we are finished our interviews and we're in the later, like we're moving into the later stages of our analysis for this first phase of the research in the suburbs, we are going to be able to do something new to extend this work. And so we're wondering what the priorities are. Okay, so I'm going to pass back to Leanne now, and thank you for your attention.
Thank you so much, Dion. Fantastic presentation. And I'd like to welcome back for the Q&A segment of today's PHO rounds our two community organization partners, both from Moyo Health and Community Services. So we have Executive Director Jillian Watkins. Welcome, Jillian. And 2S LGBTQ+ Training and Capacity Coordinator, Winston Wong. Thanks, Winston. It's fantastic to have all three of you here. And I think a quick note to everyone on the Zoom that now's a great time to enter your questions into the Q&A pod, and we will be reviewing those and bringing forward your questions for our wonderful panel to be able to speak to the things you're curious about coming out of Dion's really interesting study finding sharing. So perhaps I'll just start by offering Winston and Jillian the opportunity to make any comments, perhaps on the first question in terms of the findings of, in particular, the Peel Geography of Sex study and whether, in your view, it's resonating with other parts of Ontario, and you know, any other comments you want to make just to sort of add additional context from the perspective of the community organization with which you work to what Dion has shared.
Thanks, Leanne. Winston, did you want to go first, or shall I?
Why don't you go first, Jillian? And thank you, Leanne.
Yeah, so I think in thinking about like how these results resonate for us at Moyo, there's so many pieces, certainly like, and I think are common across aid service organizations across Ontario, especially thinking about the impact of stigma and shame on how folks access sexual health services. And the challenges, especially like in suburban and areas outside of urban centers, or areas where there are like sort of like core to us LGBTQ centers, of finding sexual health care providers that are knowledgeable, free of stigma, culturally appropriate. So we definitely find like, as we're thinking about supporting people who are living with HIV, this is a major challenge, finding service providers who are willing to take on patients and who are able to provide good support to them. But in thinking about, you know, folks needing any kind of sexual health services, preventive services, treatment of STIs, we see this as a major challenge, especially thinking about the increasing numbers of primary care providers who are retiring in Peel region. And we're really seeing this as an additional challenge. So yeah, these results like definitely resonate, and I think really help us point us in directions for like where we can focus our efforts.
Thanks so much, Jillian. So some really interesting sort of face validation from a local community organization provider for some of these findings. So Winston, go ahead.
Thank you so much, Leanne. I would like to comment on the research that Professor Dion Gesink has done, is to illuminate a huge importance between space, place, people, and sexual health and accessibility. And that there's such a big difference between different geographies and what that accessibility looks like in a general sense. And this is definitely, you know, illuminated between the city of Toronto, for example, an urban location, to the Peel region, which splits between suburban and rural locations. So this research is very important in illuminating that accessibility and healthcare desert.
Thanks so much, Winston. So really those themes of access in suburban environments to sexual health clinical services being really key. Fantastic. So what I'll do now is I'll go to the Q&A where we have some audience responses to the question about the extent to which the findings Dion presented resonates for them. So we've heard from a couple of different public health unit attendees from outside of Toronto that absolutely this does resonate. One comment is definitely applicable in the Simcoe-Muskoka District Health Unit area, so that's good to know. Another comment echoing that would be really interesting to extend the research in York Region, and likely, anticipating that it may be similar, reflecting some of what you observed in Peel Region. And another comment from a different participant from York Region indicating the findings around sort of access to clinical services resonated, particularly for the 2S LGBTQ plus population. So, I think lots of encouraging remarks about the resonance here. And keep adding those comments in the Q&A. What I'll do now is just pause and see if Dion has any responses to the comments that Winston and Jillian have made, or to any of the comments that I just highlighted from the Q&A.
Okay, so now with respect to the Q&A, so there's a lot of, thank you all for sharing feedback. And the one thing that's standing out to me is the York Region. A lot of our participants actually have strong connections to York, so that would be a natural area for us to start including in this work going forward. So that would be super great. In terms of how do we increase capacity among GPs or family docs, maybe that's something that we need to make part of the next phase of work, because that is a good question. I don't know that it's one that we have a quick answer to. I'm not sure that it's covered. I'm not sure how much it's covered in med school and versus how much should be continuing education as well. Certainly something that we could advocate for. Leanne.
Thanks, Dion.
Yeah.
And maybe I'll just add possibly a continuing medical education opportunity as well, to think about at the local level in terms of public health outreach to primary care. I can continue, Dion, helping sort of highlight some of the questions, and we can continue along because we've got a couple of good ones. So maybe what I'll do next is we have a couple of questions that are sort of additional clarifying questions about some of the research you presented, Dion. So one of them was about whether any questions in the interviews were asked about why the majority of GBMSM were not choosing to take PrEP or wear condoms, and if there's any data explaining this. I think this may have been pertaining to the initial Toronto study. I know you started to speak a bit about cost and geographic access barriers, but did you want to elaborate on either from your Toronto study or from the preliminary analysis from the Peel study, what you're finding around either barriers to PrEP or condom use?
Yeah, it's a good question. We didn't ask that question specifically, but it did come out in conversation to some extent that, at least with the Peel part of the project, guys in Peel who were interested in PrEP, if their healthcare provider was in Peel, they didn't necessarily feel like the healthcare provider would often redirect them. Either they'd say, I don't know, or they'd say, you got to go to the PrEP clinic in Toronto. And so I think as soon as you start to redirect people, you start to lose them to some extent as well, right? Like you lose people as soon as there's any kind of barrier in place. And oftentimes guys described like having to educate their healthcare provider on what PrEP even was. But I think when they would go downtown, like if they went to Maple Leaf or the hub HQ, I think they would get good care. but it just wasn't there. Different guys evaluate their risk differently around whether or not they need PrEP, and they can kind of move in and out of wanting to or feeling that they need to use PrEP depending on whether they're in a relationship that's stable or not. So there's a lot of nuance there. As far as not using condoms, so nobody's using it for oral sex. I mean, I think that's regardless of population, to be honest. People don't like to use condoms for oral sex. When it comes to anal or otherwise, then I think, again, we didn't ask specifically, but guys certainly were a bit dismissive about bacterial STIs, and much more because they can be cured. And those were sort of seen as more like the cost of doing business as opposed to a real concern. Whereas it was really HIV that they were most concerned about, and they weren't convinced that condoms was going to be the number one way to prevent HIV. And so they used a lot of other ways, including PrEP and including serosorting and positioning and those kinds of things. So I think that is that.
Thanks, Dion. Can I maybe just open it up to Jillian or Winston? I saw some head nods as Dion was sharing some of her thoughts on those questions, but anything you wanted to add from the community organization perspective at Moyo around either barriers or facilitators around condom use or PrEP that your experience supports?
Winston, did you have some thoughts on that you wanted to share?
Sure. I mean, one of the first things that popped into my mind was that there were some people who don't know about PrEP, some service providers, as Dion has mentioned, that there's no knowledge of PrEP. So I think that that's one of the barriers in informing, what PrEP is for, how it can be beneficial to one's health, especially when you're sexually active. So that's just some of my preliminary thoughts.
Yeah, and I think I'll just add to that. I think around the condom use piece, I think there's so many factors that there may be people who are on PrEP who therefore think that they're no longer necessary. There may be people who, like Dion said, just aren't interested in using condoms for oral sex and maybe find them uncomfortable. I think there's so many opportunities for like education and reminders about the importance of condom use that and sometimes there's an oversaturation of these messages and that leads to people sort of starting to disregard them. So it's about, thinking of creative ways to share this messaging, thinking about where you're targeting it, coupling messages around PrEP with messages around condom use. Like there's lots of different ways like we can try to get creative around like reinforcing the importance of those messages, especially seeing the patterns that we're seeing.
Thanks so much, Jillian and Winston. Okay, Dion, I'll bundle a few questions that are about what was included in your study in terms of the participants and how you defined geographic areas. So the first question was, how did you define urban, suburban, or rural for the purposes of this work? And presumably this applies to both the Toronto and the Peel studies. We'll start there.
Okay. And just to digress for 1 second, I think the other thing about PrEP, the PrEP question is, if you're counting on your patient to tell you about PrEP, unless they know about it, then nobody's in the know. So I think that might be another reason why there's maybe an under uptake of PrEP. Okay, so urban, rural, suburban. For the Toronto study, we considered urban. We used the Toronto boundary, so all the way up to Steeles and then to the borders of Etobicoke and Scarborough in the west and the east, and then the lake in the south. So we just considered Toronto as an urban place, but also recognizing that as soon as you start to get north of Eglinton, Lawrence area, you're starting to get into North York, Etobicoke, and Scarborough are a little bit more suburbanish or peripheral to the downtown, more urban core. So that's how we defined it for the Toronto study. For the Peel study, we've kind of treated it as there's the greater Toronto area, and Toronto is like the urban core for the greater Toronto area. And although there are sort of city-sized populations in the surrounding areas of like Peel and York and otherwise, and Vaughan, the way they're distributed geographically, like the way those places are developed, built urban geography. Not as more suburban. And so so we kind of went, so these are loose definitions. They're not official definitions of urban and rural and suburban, but we went a bit on a balance of population size and what kind of amenities and what does the physical geography and city planning look like for a place. And we were pretty much focused on the greater Toronto area that way.
Thanks, Dion. Your sound was in and out a tiny bit there, but I think to paraphrase, you were just describing that the way you defined the areas for the Peel study was a little bit flexible, recognizing different communities within Peel. Is that a fair paraphrase? Yeah,
so Brampton and Mississauga, urban-sized populations, but the layout of those communities is very suburban in their layout. Caledon is still part of Peel, but it's a much more rural kind of environment, and so that's how we defined or distinguished. If you were from Brampton or Mississauga, we considered you suburban. If you were from Toronto, we considered you urban. If you were from Caledon, we considered you more rural. And then we got into sort of like Hamilton, Guelph, we're sort of more like small cities, and versus like the places in between.
Yeah, that makes sense. So it wasn't just the boundary of the region, it was how the community actually was laid out and density, et cetera. Okay, that's very helpful. So we had a comment from a Peel family physician indicating that the findings resonated for them in terms of what they're seeing in their practice, and asking about whether you had any international students. So that's part sort of one that I'll highlight. And there was another question asking about whether you inquired about occupation in the study. For example, thinking about the context of shift work as one of the factors informing how people would seek healthcare, for example.
Great questions. And maybe Winston, if you can help me remember, I am not sure how much we asked about occupation. And I think it kind of came out in conversation, whether someone was a student or if they were studying or if they were working somewhere. I'm not sure if I can't, to be honest, I have to go back and look at the interview guide to figure out if we actually asked occupation. Winston, do you remember better? Because Winston read through all of the interviews.
Yeah, I have to go back into the notes and into the interviews and look, but the occupations ranged from what I remember. In Ontario, there are different levels of occupation that range from numbers like 0 to 12 or something like that. But the numbers range, right? So everyone's from different, jobs, employments. But one key thing to remember during the pandemic period is that a lot of the occupations geographically were limited to either the home and domestic work at the home. So and that combines school as well and education.
Okay, thank you so much. We have lots of great questions, so I'm going to continue moving through them. So there's a question from York about whether there was any awareness of public health sexual clinics mentioned among study participants, noting that that is another path for accessing clinical care. And I know, Dion, you sort of explained different places that participants accessed testing, including breastfeeding clinics, which was interesting. Yeah, do you want to comment about whether that figured into the feedback you heard?
So I think there was a full range of knowledge about where people could access sexual health services, and some knew about the public health clinics, but not everyone did. And one of the things that our interviewers did was paid attention to what did people know, and they made sure that the participants at least were connected with Moyo if they weren't already. so that they could get a more fulsome understanding of what was available to them. But I would not say that it was top of mind across the board that people knew that there were public health, sexual health clinics. Winston, am I missing anything?
I think you covered basically all of it. Yeah. I mean, as you've mentioned in the presentation, the healthcare desert, it exists in the sexual healthcare desert exists in the Peel region. And as you've seen in the map earlier, downtown Toronto has a large concentration of healthcare clinics. And maybe knowledge that even, in sexual health, but as we cross into Peel region and more northwards as well, there, a sexual healthcare desert is quite prominent.
Thanks, Winston. So on the theme of sort of geography and access, we have a question from one attendee about whether researchers are looking for other geographic regions in Ontario to look more broadly for trends or gaps in services. So Dion, any comments there about either where this research or other colleagues' research might be going in this area?
Oh yeah, we're definitely interested in, like, please contact me if you think that you want this to expand to your area, because like what we've done so far is qualitative, and it's giving us great depth of information, but we don't know how to prioritize it or how widespread it is, or whether it's generalizable to other areas. And that would be like a next step for us, would be to start saying, are there other communities that we can collaborate with? Because it's not easy to reach guys who are gay or bisexual, or who are identify as heterosexual but have sex with men outside of the urban areas. Even in urban areas, they're hard to reach, but when you get into the suburbs, they're really hard to reach. Like, our recruitment strategy was a very well-developed plan by one of our partners at Moyo, who spent a lot of time and energy to just get those 44 guys. And we've looked at the Sex Now data, which goes across Canada, and tried to like even looking at how many guys Sex Now is able to recruit for the quantitative study. They're not much more than what we've managed to get for the qualitative for Peel region. So it really means that if we want to try and look at these questions in a more quantitative way, to start getting ideas around like what's the prevalence of these different issues, and we need to start expanding the geography to other suburban, small city, large city, but that sort of loose definition that we've made, that's sort of very much based on how a place is organized more than the size of its population, in terms of defining suburban.
So a related comment from one of our attendees is that in the Simcoe-Muskoka area, many clients work and play and seek testing both within their own area, but also in nearby areas like York, Toronto, and Peterborough. So I think this relates a bit to trying to expand the scope of what you might be studying. And Dion, you're talking about like mixed methods or other complementary methods as well. But did you have any just kind of additional comments to add on to that? Just that this phenomenon of course, like crossing jurisdictional boundaries, and of course, you've got, you're trying to study in your Peel study, but being able to kind of look at those intra-provincial patterns, I guess.
Yeah, so this is actually a question that we're looking at right now. As a doctoral student of mine is looking at, where do people live? Where could they, like, what's the closest place they could access sexual health services, and where do they actually access sexual health services? Because we don't actually know, like, are people going based on where they live or where they work, or where they feel like they can get good care or competent care, or where they feel comfortable? Anecdotally, I've Women's Health and Women's Hands has a catchment that includes women who come from Windsor, Ontario to downtown Toronto, because they feel more comfortable seeking care at Women's Health and Women's Hands than they do in Windsor. So sometimes people are willing to really travel for care, I think, but that's not necessarily true across the board, because there are other people who are like, unless it's very convenient for me, I'm not going to go that far. But we definitely see, like, and that's maybe a question worth looking at more, is like, how do people make decisions around where they're going to access their care?
Thanks, Gian. So a related question in terms of thinking about online services was, did participants report using online services in the suburbs? And if so, did that impact their view of how accessible sexual health services were?
So people identified liking being able to request STI testing remotely, like that online piece. And I know that so from other studies, so we didn't look at that question directly, but it did come up a little bit in our interviews. And then in other studies I've been involved with, a lot of guys have said, my ideal experience is I would go online, download a requisition, walk to the lab, submit my sample, and look up my results online. And I think there's the large study out of BC, and BC now offers like getting checked online, and that seems to be working really well there. And so there's a question about whether or not that's something that we should be doing more in Ontario as well.
And did you have any findings specifically with respect to PrEP and accessing online services? That was another part of the question.
I do not remember, but Winston, do you remember? I don't think we had people talking about accessing PrEP remotely. I think that one required, they pretty much were being directed downtown, and then as opposed to online.
Thanks. And maybe just to circle back to the sort of the multi-jurisdictional question, we have a comment from York saying that they see people from York, Toronto, Peel, Simcoe, and Durham. So really lots of movement across those public health unit jurisdictions there. There's a question about whether I guess the research team has considered RDS or consulted with the ENGAGE study. So I'm not familiar with those two myself, but perhaps you could speak to it.
Yeah, so some of the ENGAGE study co-investigators are on this study as well. And we've not done respondent-driven sampling because we're not trying to estimate a prevalence or anything like that at this point. There's not a need to try to figure out how much of the network we're actually getting, but that would be an interesting approach if we were trying to get at that those kinds of more, to get more of a sense of how much of the network are we capturing. So respondent-driven sampling, the way it works is you try to limit an amount of bias that might come from having one participant who's got a really tight network and a large network, and you get a large sample from that one person's network. So it allows for rebalancing, but we're not doing the kinds of stuff that the ENGAGE study is trying to do. This is very much a qualitative study, and it's really about experiences of guys in the suburbs and in Peel region.
Thanks for that compare and contrast in that context. Dion, perhaps I'll just ask a probing kind of question about your recruitment strategy, because I don't think we necessarily reviewed that in detail in your presentation, and just maybe sort of very briefly as a qualitative study, if you could highlight how you did actually succeed in having 44 participants in the Peel study.
Yeah, so for the Peel study, we took a multi-pronged approach. Like I mentioned, Jodh Singh set up a large sort of a combination of a drip campaign online. He used Instagram ads and Facebook ads and Google ads, and he also used Pornhub and put ads on Pornhub. We used a bit of a network sample as well and asked people to share through their networks. Maple Leaf Prep Clinic posted for us. There was also, we posted signs and woodies when things were a little more open. Peel service providers would post things for us. Region of Peel, I think, managed to post some things in their clinics as well. So we did a combination of in-person and online campaigns to reach people, and then network, just sort of get the word out as far and wide as possible. And we were trying to have diversity. So it was a purposive sample. You had the gay, bisexual, straight, you just need to have sex, be a man who had sex with men, and you needed to live, work, or socialize in Peel region. And we were looking for diversity by a little bit by gender, but more by race and age and geography. And then for Toronto, it was a little bit similar. It was definitely like online campaign as well as in person, and posting flyers all over in cafes and restaurants and bars and on the community boards in Toronto and surrounding areas, and then online, and also using influencers. So we for Peel, we had a drag queen share our study, and someone else that was part of the community shared it.
Thanks, Jan. I think that's helpful, just context for the variety of strategies that were used, it sounds like, to achieve that sample size. We have a few more questions and we have a bit more time. So I will get back to the Q&A, but first I just wanted to perhaps give both Winston and Jillian a chance to share any comments they might have about the second set of questions on your penultimate slide, Dion, which was about what are the potential next steps, what are some emerging priorities that you perceive coming out of this research for public health organizations, for health services, et cetera. So maybe Winston first, and then Jillian, just really welcome you to share your perspectives on that.
Thank you, Leanne. So I was taking just some notes, but this is to say that throughout the research project, that there appears to be such, at certain degrees, right, implicit and explicit, dynamic geographic definition of healthcare, sexual health, of queerness, and thus outness, how out someone is. Which then determines almost, what someone's sexual healthcare practice and activity looks like. So this is just something that's super important, that geography does completely matter in research and how, one accesses sexual healthcare, and thus, the transmission of STBBIs and HIV. Which also means, the externalization of this data to other jurisdictions and geographic networks, such as York Region, is super important and is a great consideration to take in. So that's just something that I had on my mind, which also contributes to how we define, men who have sex with men, or gay and bisexual men who have sex with men. So those two definitions, geographically, it has an implicit bias and explicit, meaning geographically. That's different from each other.
Thank you, Winston. Jillian?
Yeah, I'm thinking about where can this research go? What are next steps? Dion spoke to this a little bit already, but understanding why people are making choices about their healthcare providers and where they might go to access preventive sexual health services, I think is really interesting and something that could really help inform the work that we're doing at Moyo. So asking those questions about, what are you looking for? What would prevent you from accessing care in your own, near where you live? And therefore what might we be able to do and others be able to do to encourage accessing care more locally? And some of it is about availability of services. And we talked already about some of it being about appropriateness and cultural appropriateness and knowledge of healthcare providers. So I think that's another piece that is really interesting to explore, is speaking with healthcare providers about why aren't they offering PrEP, or why aren't they initiating those conversations? What do they know? And those are opportunities for organizations and community serving organizations like Moyo and others to do that engagement with clinicians, share information, education, and then also would be helpful in connecting people who are seeking services to the right places. So yeah, I feel there's so much potential to ask these deep qualitative questions, understanding the why of where people are traveling and why.
Thanks, Jillian. Perhaps I'll pick up on the healthcare provider or clinician component of your comments and link back to some of the remaining questions in the Q&A. So we have one question about whether and to what extent there is inclusion of sexual health and 2S LGBTQI plus and health equity advocacy, and I think probably content in medical training, and I think you could extend that to healthcare provider training. And then there's another question about whether there is any strategy that you're aware of around supporting physicians and nursing, physician or nursing colleges to increase skills in respect of providing LGBTQ friendly care, and as well as keeping up with their sexual health related knowledge and skills. So just welcome any comments. I mean, perhaps from the how do you contribute to this where you are positioned, Jillian and Winston, and just thoughts from the entire panel on opportunities you see there.
Yeah, I can share one example, which is that like at Moyo, we have medical students who do like brief like internships at Moyo, where they get connected with, like, learn about the programs that we offer, learn about like the specific health needs of the populations we support, people living with HIV and 2S LGBTQ populations. And I think like those types of interactions are so valuable. They don't have a lot of time, like, because they obviously have really packed education programs, but like even the chance to like come out to, you know, local community services, engage with folks who are accessing information and education there, and learn about like the key issues affecting the populations is, I think, really valuable.
Thanks, Jillian. John, anything you wanted to add there that you're aware of that you wanted to share?
No, but it's definitely making me think that if there is no CME credit available for physicians and nurses to learn this stuff, maybe it's time we created that, at least as a first step in providing a resource. And then move to advocacy.
For those who attended today, there is an opportunity for CME, which is great. But I would imagine there, both undergraduate and postgraduate medical education curricula, are likely, taking a CQI approach to continuing to look for opportunities to strengthen these content areas. And certainly, learning from colleagues like yourselves can only help. So thank you for sharing your expertise today. I'll go to, quite a specific and interesting question that we have that is aligned with the next steps conversation. So considering the clear findings and challenges in making changes on the service provider end from your research, is it worth exploring the development of demonstration models that can showcase potential solutions? So for example, to serve as a prototype or proof of concept, for how some of the challenges that you've identified could be addressed effectively. So any thoughts there on sort of innovative or model approaches or practices or services, and how to either study that further or highlight successes?
So I'm not entirely sure what, I feel like this might be physician speak that I'm unfamiliar with in terms of demonstration models that can showcase potential. Are you talking about like scenarios for like in med school when students are learning how to have conversations with people about, for instance, taking history or those kinds of things?
I'm not sure if that's what the question was about. I think it could be about some of those like positive experiences that you were highlighting and settings, healthcare settings or service settings that really are doing exemplary work, I guess, in that area. And maybe one thing I was curious about is just even, the interesting finding about the symbols of LGBTQ plus friendly services. So has anyone actually looked at that empirically to see the extent to which those symbols are present in primary care, for example?
Yeah, this is all definitely beyond what we've done, but so the symbology definitely comes up in pretty much every study that I've been involved with, where people talk about like getting visual cues, even if it's nonverbal. Those nonverbal cues can be really important to know that it's a safe space or place that somebody's going to. It is an interesting, I mean, one of the things that I like to do is sort of create short vignette type 3.5 minute long videos that kind of like digital story type things that can persist beyond the life of a study so that people have access to information. So it might be an idea to like, a good idea to create some digital stories about positive experiences and what those look like, or how to have a conversation with somebody, or just assume like, I'm almost at this point in my life where I just assume everybody's queer. And instead of trying to like ask the question, just, you know, maybe have a conversation about like, we could potentially run some digital stories or something around like how to have these kinds of conversations. Yeah.
Thanks, Dion. Okay, I'll wrap up our Q&A with just sharing a comment, one final comment around an example of where public health, sexual health clinics, in this case in York, are providing training to family practice residents and or medical students. So, you know, certainly even in that context of clinical services, there is an opportunity for learning for healthcare providers, absolutely. Just sharing for awareness, there is a website that perhaps we could share and follow up around access to training around PrEP prescribing. So that's something that could be shared. Okay, so we are almost at the hour and a half mark. So I want to say a sincere thanks as I wrap up today's PHO rounds to Dr. Dion Gesenk for her wonderful presenting. And I also want to extend a sincere thanks to Jillian Watkins and Winston Wong from Moyo for their expertise and the extra context that they shared. Thanks to everyone who shared a big part of your Tuesday workday with us to join today's webinar. We will share a brief and anonymous PHO round survey from today's session. We really do appreciate your input to help us keep improving our programming. And we will have, with the consent of the presenters, rounds presentations available for sharing on the website. So you can look generally to access PHO rounds past presentations on our website. You look at education and events and you click on presentations there. So have a wonderful day. Thanks for your attention. And thanks again to Dion, Jillian, and Winston.